Hello, so my name is Mohsin Bart. I'm a doctor and clinical research fellow in neurogastroenterology, working in London and Nottingham in the United Kingdom. So in today's talk, I'm going to be talking to you about a condition that we regularly see in our tertiary care neurogastroenterology service, and that is gastroparesis. So we're going to be talking to you about what gastroparesis is, how the condition can be diagnosed, and how it can be managed. So a diagnosis of gastroparesis requires three conditions to be met. So number one is that there has to be a delay in gastric emptying. So that means that there is a delay in how quickly the stomach empties contents into the small bowel. Number two is the absence of a physical obstruction to the flow of food from the stomach and into the small bowel. So what that means is that there is no tumour or mass or stricture that's stopping food from flowing into the small bowel. Number three is the presence of typical, also known as cardinal symptoms of gastroparesis. And those are typically nausea and vomiting, especially of undigested food shortly after eating. And patients may also complain of indigestion-like symptoms, and those can include things like early satiety, which is where people feel very full only after eating a small quantity of food, postprandial fullness, which is an unpleasant sensation like the persistence of food in the stomach after eating, and also bloating and pain in the upper part of the tummy, known as the epigastric region of the abdomen. So the delay in gastric emptying is quantified using carbon-13 breath testing and also gastric scintigraphy tests. The values for gastric emptying will depend on the type of meal eaten, and so it's important that the lab that analyzes your traces uses the correct reference ranges for the type of food that you've eaten. It's also recommended that gastric scintigraphy tests occur over 4 hours to ensure the accuracy of results. An endoscopy or camera test is often used to visualize the stomach, the upper part of the small intestine known as the duodenum, and that's basically used to ensure that there's no physical obstruction to the flow of food like a mass or a stricture. Now, before an endoscopy, patients are asked to have an overnight fast or to fast for a particular period of time beforehand. Now, the presence of food in the stomach after an overnight fast may be suggestive of gastroparesis, but it cannot in and of itself be used to diagnose the condition because you need to quantify the degree of gastric emptying using the carbon-13 breath testing or the gastric scintigraphy tests before you can diagnose gastroparesis conclusively. A clinical history is also really important to ensure that you can differentiate between gastroparesis and other conditions that might mimic gastroparesis. And those conditions can include things like cyclical vomiting syndrome, functional dyspepsia, narcotic bowel syndrome, and also some types of eating disorders. Now, the symptoms of gastroparesis and functional dyspepsia are almost identical, so it's very tricky to differentiate between both conditions. And moreover, there will be a proportion of patients who have functional dyspepsia who will have a degree of delayed gastric emptying. However, it's the presence of that regular nausea, regular vomiting, especially of undigested food, that will help a clinician to differentiate between gastroparesis and functional dyspepsia. Cyclical vomiting syndrome, also known as CVS, is another functional GI disorder. It's a disorder of gut-brain interaction, and that is where patients have these intense episodes of severe nausea and vomiting, which are interspersed with these episodes where patients are completely asymptomatic, so they have no symptoms of nausea, no symptoms of vomiting at all. However, gastroparesis is more persistent, so it doesn't have these distinct episodes or these distinct clusters of nausea and vomiting. And moreover, cyclical vomiting syndrome is associated with a family or personal history of migraine. Eating disorders such as anorexia nervosa or bulimia nervosa might cause delayed gastric emptying and produce symptoms that might mimic gastroparesis. but it's important that clinicians identify whether an eating disorder exists, because if it does, then the mainstay of treatment is generally going to be more psychological therapy, and there's going to be less of an emphasis on using drugs such as prokinetics to increase the speed of stomach emptying. Narcotic bowel syndrome is where patients have worsening abdominal pain with increasing doses of opiates such as morphine or tramadol or codeine. In addition to this abdominal pain, patients can also develop nausea and vomiting, which can mimic gastroparesis. Now, as gastric emptying can be delayed with opiate medications, it's important that opiates are excluded for a duration of time before the gastric emptying tests are done to ensure the accuracy of results. So people who have gastroparesis can manage their condition with both lifestyle changes and medications. So firstly, when it comes to lifestyle changes, patients should have smaller, more frequent meals that are interspersed throughout the whole day. And they might wish to consider removing food groups that might reduce stomach emptying, such as high-fat foods, high-fiber foods, but foods should only really be excluded after one consults a qualified dietitian or a qualified nutritionist who can help you to identify the food groups that are triggering your symptoms of gastroparesis. Reducing the intake of fizzy drinks is also quite helpful to reduce bloating. Medications can also be prescribed by a doctor, and those are used to increase the speed with which the stomach empties food into the small bowel. Now, medications which increase the contractility of the stomach are things like erythromycin and metoclopramide. Now, these prokinetic medications, which improve contractility of the stomach, have a number of different side effects. So it's really important that one is very closely monitored by a qualified medical professional, and that patients use the smallest possible dose for the shortest duration of time. Second-line drugs can include things like prucalopride, and that is particularly helpful if patients have coexisting constipation alongside their gastroparesis. Enteral feeding is where a food pipe is passed through the nose, through the gullet, and through the stomach and into the small bowel. So what that means is basically the food is bypassing the stomach and goes directly into the small bowel. Now, enteral feeding is only used in the severest of cases of gastroparesis because it's associated with a number of different dangerous side effects, and patients are expected to liaise very closely with their nutrition team. Now, there are very strict criteria for starting enteral feeding in patients who have gastroparesis, and because malnutrition and weight loss are often only present in the severest of cases of gastroparesis, patients who have mild to moderate gastroparesis and have weight loss or malnutrition should really be worked up for other potential causes of their malnutrition. So things like cyclical vomiting syndrome or eating disorders, which might mimic gastroparesis. Gastric electrical stimulation is a new therapy for gastroparesis that has very recently been approved by the National Institute of Clinical Excellence, so NICE, for the treatment of gastroparesis. Now, the evidence is conflicting as to whether gastric electrical stimulation actually works. And there are some studies that have suggested that the symptoms of gastroparesis don't necessarily improve when patients turn off their simulator compared to when it's on. So this is a new therapy that really does need some more research into it. So to summarize, we've gone over what gastroparesis is, how it can be diagnosed, the conditions that might mimic gastroparesis, and also the management of gastroparesis, which is dependent on both lifestyle changes and also medications. So I hope this video has helped you to understand your condition in more detail. And if you've enjoyed the video, please like, please subscribe, and please share. Thanks so much.